I think I'll have to be allowed to share my screen.
Yes, sir, you can share.
Great. Okay. So, like was said in the introduction, we have the World Brain Tumors Day on the 8th of June. And what I am trying to do today is to give sort of an overview of pediatric brain and spinal cord tumors. When Dr. Guve was talking about my overall experience and the various fellowships I have done, I think one most important thing through all these fellowships is not the technical or the neurosurgical learning and exposure that you get. Obviously, as a neurosurgeon, I know it is important for you to learn the technical and the surgical nuances of any surgery, including brain and spinal cord tumors. But I think what I have realized and understood in the last 6 years of having worked only in pediatric neurosurgery is that the world of pediatrics and the world of pediatric brain and spinal cord tumors is a completely different ecosystem. Therefore, whatever knowledge and whatever understanding and instincts that I developed as a neurosurgeon during my training and for the 5-6 years before I got into pediatric neurosurgery, I did realize as years passed on that a pediatric neurosurgeon needs to think very differently, because the conditions, even though brain tumors present both in adults and pediatrics, the pediatric brain tumors are a different ballgame altogether. Their presentation, the approach that they need, the complications that can happen, and the way you counsel a family and a child are way different from what we would do in adults. And I think as I'm spending more and more time in pediatrics, I realize that I'm only learning every year, every day. So that's why. So the first point that I wanted to make is pediatric brain and spinal cord tumors are very different from the tumors seen in adults. So with that, just wanted to give sort of a brief overview of the normal anatomy. Please forgive me if you feel this is too basic, but I thought, we could just sort of brush up or sort of have a quick look at how the brain looks like and basically what we are trying to see, and as surgeons, what we are looking for. So if you see on the left side, this is a cadaveric brain. On the right side, there are some, parts which are labeled. Without getting into a lot of detail, I just want to point out the few lobes that the brain has. So if you follow my cursor here, this is the central sulcus. This is the central sulcus, which means that everything anterior to the central sulcus is the frontal lobe. So all of this is the frontal lobe. It is one of the biggest lobes of the brain. Everything posterior to the central sulcus is the parietal lobe. So everything here is parietal. This portion is the occipital lobe, and this is the temporal lobe. So although it sounds simplistic, but the definition of frontal lobe is anything anterior to the central sulcus is frontal, anything posterior to the central sulcus is parietal, obviously temporal and occipital. Frontal lobes has 3 gyri, superior, middle, and inferior. Temporal lobes also has 3 gyri, superior, middle, and inferior. And like you can see, this is the most critical part for any neurosurgeon, because anytime you have a lesion around this area, this is the motor strip. This is the motor area, and this is the sensory area. So when we talk about eloquent areas, why I need to highlight this is because, that has a very big impact, because especially with tumors and also with other lesions, of course, since I'm doing epilepsy as well, the important eloquent areas of the brain are one here. So if this was a dominant lobe, say this is a left-sided dominant lobe of a person, this area here is the Broca's area. So you can see an M-shaped structure. Let's not get into the details of the names, but this is the Broca's area. And between the frontal, parietal, and temporal lobe, you're seeing this big fissure here. This is separating the frontal and the parietal from the temporal lobes. This is the Sylvian fissure. You see SYL as it's labeled. So you have the Broca's area here. Then you have the central sulcus here, motor strip, sensory strip. Then when the Sylvian fissure goes backwards, here there is the Wernicke's area. Now, when I'm oversimplifying the Broca's and the Wernicke's area, what I'm trying to tell you is that the language network with with detailed understanding, it has come out to be that the language network is very, very complex. In fact, it is very difficult to say that only this area is Wernicke's in this patient and only this area is Broca's. For that, obviously, we have to do functional MRI and many other things to establish that before we decide to operate. But generally, whenever a surgeon finds a lesion somewhere here, or finds a lesion somewhere here, or finds a lesion somewhere here, these are eloquent areas of the brain. Which means that in these areas, if I do surgery, there is a risk that I can give a deficit to the child. And therefore, there have to be various tools and various thought processes and approaches to decide if we can operate, and if we have to operate, how we operate. Now, one more important thing that I need to point out in these two diagrams is this part. You can see this this differentiation between everything above and everything below. Here again, this is the cerebellum, like you can make out, and these are the lobes, the cerebral hemispheres. In the normal brain, what divides the cerebral hemispheres from the cerebellum and the brainstem, because this is a cadaver, the brainstem is removed, it should have been here. There is a leaflet of dura here called the tentorium. Over here, I'll show it to you on further images, but there is a leaflet of dura called the tentorium. Therefore, you will hear the terms supratentorial tumors versus infratentorial tumors when we talk about brain tumors. So basically, supratentorial tumors means everything above this, means the cerebral hemispheres. Infratentorial tumors means everything below this. Imagine there is a curtain here, there is a leaflet here. Everything below this is an infratentorial tumor. Obviously, brainstem tumors are also included. We don't see the brainstem in this cadaveric specimen. So this was basically sort of an orientation of the brain anatomy. I think passingly, it is also sort of necessary to brush up on how the ventricles look like, because every time that we talk about a brain tumor, we talk about a tumor pressing on certain critical structures, and one of the most important structures in the brain are the ventricular system, which is necessary for CSF drainage. So if you look at this illustration, we have two lateral ventricles. This is one lateral ventricle that we are seeing. So we have two lateral ventricles. Then every lateral ventricle drains through a foramen of Monro. So this is the foramen of Monro here. So therefore, we will have two foramina of Monro on both sides. So two lateral ventricles, this is one of it, drains through a foramen of Monro into the third ventricle. Now you can see here, this is the third ventricle. And from the third ventricle, we again have a single duct called the aqueduct of Sylvius. So this is the aqueduct of Sylvius, which is exactly in the midline, and the aqueduct of Sylvius drains into the fourth ventricle. So this is the normal anatomy of the ventricular system. Lateral ventricle, foramen of Monro. This is a foramen actually, although it looks like a tube. Third ventricle, aqueduct of Sylvius, fourth ventricle. Now, if we go on to this cadaveric specimen here, again, if you look at my arrow, this is the lateral ventricle. This is the lateral ventricle. This is the foramen of Monro. Obviously, this is a midline cut, but remember there are two foramina. So we are just showing one ventricle. Lateral ventricle, one foramen of Monro, then the third ventricle. From the third ventricle, the CSF flows through this, which is called the aqueduct. And from aqueduct of Sylvius, the CSF comes into the fourth ventricle. And like I said, supratentorial versus infratentorial, you have to bear in mind that whenever there is a tumor which is in the infratentorial location, you can see how everything is so compact here. The supratentorial compartment is a way bigger compartment. The infratentorial compartment is a way smaller compartment. Therefore, whenever there is a lesion here, the chances of the patient having obstruction of the aqueduct and the fourth ventricle is very high. Therefore, what will happen is everything proximal or upper to the aqueduct, that means the third ventricle and the lateral ventricle, will blow up. They will increase in size. And therefore, these patients actually present earlier on with symptoms of raised pressure due to hydrocephalus. So I think this is one thing which needs to be borne in mind when we talk about supratentorial versus infratentorial tumors. This is again, although I've labeled it as a neurosurgeon's view, but this is actually a cadaveric view. Just wanted to show you the layers and how we open. So like you see, this is the skin. The whole skin flap has been reflected. Then you have the skull. You do your craniotomy. Beneath the skull, this layer here, which is labeled number 3, is actually the dura mater. So we cut the skin, then we cut the bone, we do a craniotomy. Beneath the craniotomy, there is the dura. The dura has to be opened, and then the brain shows up. And of course, this is a very, very, very open and quite an exposed brain. We do not have the liberty and the luxury of seeing such an exposed brain in a live patient. This is obviously a cadaver, and hence it has been opened so much. Now, I thought since we are going to see a few MRIs, I will just brush up quickly about how at least one or two important sequences, which I think every referring doctor needs to know. So first of all, these are MRI images. What I need to point out is basically this image in the top row, versus this image in the bottom row. First of all, remember these are T1 sequence MRIs. Now, how do you identify that they are T1 sequence MRIs? Always, like I told you, these parts of the brain are the ventricles. So these black parts here, these are the ventricles. So ventricles contain CSF. Therefore, a sequence of an MRI where the CSF is black is called a T1 weighted MRI. Now, again, there are various views that we see in T1. So this is a sagittal view, which means that we are looking at the patient from a side. So the first one is a side view. You can identify this by looking at the nose. So when you can see the nose of a patient, and more laterally when you can see eyes of the patient in the front, so this nose tip, you can realize this is a side profile. So this is a sagittal view. This is the axial view. So for example, imagine that your patient is lying supine in front of you and you are at the head end. If you have to slice the brain of the patient in such a way that you are looking from the top of his, so the patient is lying supine and you start slicing the brain such that you make cuts facing top to bottom, you get these views. And these are coronal views, meaning now the patient is standing in front of you and you are slicing the patient anterior to posterior. So basically, coronal is anterior to posterior. So someone is standing facing you and you go on slicing his brain front to back. That is coronal. Axial means the patient is lying supine with his head towards you and go on slicing his brain from top to bottom. That is from head to toe. That is axial view. This is the sagittal view. Now, how do you decide whether it is contrast or post-contrast? So remember, do not pay attention to the pathology because this is not relevant. What you have to see is you can see these white dots on these images over here. Over here, you can see these white dots here. In fact, you can see these blood vessels which have lit up over here. Then again, here you can see this whole venous system. This is the superior sagittal sinus. These are the internal cerebral veins. This is the vein of Galen. And from here comes the straight sinus, and then again, inferior sagittal sinus. So you'll see, compare this image to this image. You do not see anything that has lit up over here. So therefore, from this, you can make out a difference that this is a T1 sagittal, whereas this is a T1 post-contrast. I know there are some white things seen here. So whatever is seen, so first you have to decide whether it is T1 or T2. So if CSF is black, it is T1. Then after it is T1, whatever is white is actually fat. So this white here is actually subcutaneous fat. So whatever we are seeing white here is not contrast enhancement, it is fat. But if you see inside the brain, nothing is lighting up here, but on contrast, things light up. So this is a T1 plain and this is a T1 post-contrast. Now, why do we use the T1 weighted MRI? We primarily use it for gauging and assessing the normal anatomy of the brain and also for contrast imaging. The next most important sequence is a T2 weighted MRI. Again, like you can make out the difference. CSF was black here. You come here, CSF has become white. So when you see white CSF in the ventricles, that tells you that this is a T2 weighted MRI. And a T2 weighted MRI, again, like you can see, I hope you can tell now, this is the sagittal, the side view. And again, like I was talking to you about the tentorium, this is the tentorium. This dark, I don't know if you'll be able to appreciate this dark leaflet here is the tentorium. So the frontal lobe, the parietal lobe, the occipital lobe, they're all above the tentorium. The cerebellum, the midbrain, pons, medulla are all below the tentorium. Therefore, an infratentorial tumor will only be here. So you can imagine how less of a place here there is, and hence the symptoms are earlier on. This that you see here is the basilar artery. This is a very critical structure, but it lies anterior to the brainstem. And of course, this black structure here is the corpus callosum. Not so much more important for brain tumor surgery unless there's a tumor there, but obviously for epilepsy surgeries, corpus callosum is a very, very important landmark. Again, here, this is a coronal view, this is an axial view. Now, why do we need T2 weighted MRIs? We need T2 weighted MRIs primarily for seeing anything related to fluid. So if you want to remember, T2 is fluid. So edema, fluid, and cysts. So if you want to see edema, you look for a T2 weighted MRI. So identify the T2 plates, see if there is edema or not. So edema will show as white intensity here in the brain. Fluid, so if there is a solid cystic tumor, you will see fluid. So wherever, so for example, all this white here, so see fourth ventricle as CSF, so it is fluid, it is white. So everything that is fluid is, yes.
Little slow, otherwise we'll get epilepsy.
Okay, no problem, sir. Definitely, I'll go slow. Yes. So everything that is white here is fluid, and that is what T2 is important for. So basically, with this sort of an overview of the T1 and the T2 weighted MRIs, I thought I'll just project the spinal cord anatomy to you as well. Primarily, this is the whole spine. Again, I'm sure you'll be able to make out this is T2, where you can see CSF, and there is, so these are the vertebral bodies in a spinal MRI. So this is, again, we are seeing from the side. I'm sure you can compare this to this imaging. See, so this imaging, when you continue down, shows the spine. So again, these are the vertebral bodies starting from the C2 going down, and these are the spinous processes. This is how a spine MRI looks. From, you can see the pons, the medulla continue down as the spinal cord. This gray thread is the spinal cord. Normally, there should be CSF in front of the spine, and there should be CSF behind the spine. Whenever there is anything that obstructs the flow of CSF in the spine, this CSF intensity behind or in front of the spine gets obliterated, and that tells us, the radiologist or the surgeon, that there is some sort of compression happening. Again, now here, this is also another T2 weighted MRI. On a cross section, I just thought I'll orient you with, quickly orient you with the anatomy. So this is the spinal cord. There are two sets of rootlets, the ventral and the dorsal rootlets, and we join together to form one nerve root. This is the gray matter of the spinal cord. You have your posterior columns and your spinothalamic tracts generally posteriorly, and corticospinal tracts are somewhere anterolateral. Here again, in a vertebral body, this is the vertebral body. This is the lamina. This is the spinous process. This is one vertebral body. So you can imagine the spinal cord is here in between. The roots come out here through the foramen. This is the vertebral artery. So remember, if there is anything that impinges this root, either because of, this bone here being problematic, or there is some tumor in the spinal cord which presses on this root, it will lead to radicular symptoms, which can be pain, which can be tingling in the distribution of the spinal nerve. So with this sort of overview of anatomy, let's go forward to, what are the various clinical presentations or manifestations that brain tumors can cause. Obviously, we all know, one of the most common presentations of brain tumors are raised intracranial pressure. So headaches,
I just want to thank you for giving us such a overview of MRI and the anatomy of the brain. This is something that we really needed refreshment about.
Thank you, ma'am. Thank you so much. So again, obviously, when we talk of brain tumors, we talk of raised intracranial pressure, and headache obviously is one of the most prominent symptoms in the triad, in fact, of raised intracranial pressure, the Cushing's triad, which obviously we do not always see, but headache. Now, what are the features of headache that you need to ask someone when you are suspecting raised pressure? So early morning headache. So these questions sometimes help clinch a diagnosis, which can sometimes otherwise delay the diagnosis in a patient, because headaches, many kids present with headaches. And if this one question can help an early diagnosis, even 1 in 100, I think it can save the life of a child. Now, they say that the various theories for early morning headaches are: one, obviously we are supine overnight, and hence there is venous congestion. So the venous return from the brain is impaired overall at night. The CSF, which drains due to gravity, that CSF pooling happens overnight because there is no gravity. And they say that there is some element of CO2 retention. Therefore, what happens is suddenly in the morning, when the child or the patient for that matter wakes up, the brain is swollen. And obviously, if there is something which is already there in the brain, as you know, the brain is a closed box. There is no the Monro-Kelly doctrine or hypothesis. There is no extra space in the brain. Therefore, whenever there is no extra space in the brain, a small tumor leads to raised intracranial pressure, and these three factors lead to initial early raised pressure in the morning, and hence an early morning headache can be a big clincher of diagnosis. Also, headache relieved with vomiting. They say, again, it's difficult to say why headache is relieved with vomiting, but it is generally said that the hyperventilation that happens with retching and vomiting, it leads to a CO2 washout. And like we all know, whenever CO2 is retained, there is increased headache. And obviously, this might be nature's way of relieving raised intracranial pressure, and hence headache, which is relieved with vomiting, is again a very critical question which can be asked to a patient and which can make you think that maybe these are some ominous features of headache. Obviously, nausea and vomiting, drowsiness and lethargy. Now, increasing head circumference. Obviously, this is very, very critical in pediatrics, especially on, there is a group of tumors called the congenital CNS tumors. Basically, any CNS tumor presenting within the first 6 months or maximum up to 1 year of life is considered a congenital CNS tumor. And it is hypothesized that maybe the beginning of this tumor was from antenatal life. Such tumors can actually present with increasing head circumference, and many times the diagnosis can be delayed, thinking that this is hydrocephalus. And obviously, the treatment need not be expedited. So increasing head circumference is a very important symptom in infants. Seizures, obviously, depending on where the child is, the seizure and the semiology will change, where the tumor is in the brain. Behavioral changes, obviously more in the frontal lobe, but also the parietal lobe. They can be, and when I talk about behavioral changes, I talk about everything from change in personality to judgment to executive function to going to the parietal lobe, where you can have non-dominant symptoms like acalculia and agraphia and so on and so forth. So primarily, the question that you can ask the family and the child is the child behaving as he was behaving before? Is he undertaking activities at school and at home, like writing and maths and understanding questions as he could do before? All of these, even though these are subtle questions, these can point to something going on in the brain. Otherwise, behavioral changes could sometimes be attributed to just tantrums and mood in children. Obviously, speech disturbances. When there are obvious speech disturbances, again, like we know, there are two types of speech disturbances: grossly, motor due to Broca's, and sensory due to Wernicke's. So if a child has a lot of jargon speech where, they speak gibberish, they speak words which do not make sense, but they have a lot of words to say, that is indicative of Wernicke's aphasia, which means that the child wants to express, but the motor part of his brain is not giving him the right words. So therefore, he's using gibberish. On the other hand, Broca's aphasia is motor aphasia, which means that the motor expression of speech is impaired. Hence, the child will use gestures, the child will nod his head, but will not be able to put words to what he wants to say. So these can be the clinical presentations. I think this, even though this sounds very neurological, I would very strongly suggest to every examining physician and pediatrician to, this takes 1 minute to examine. But so many patients, as I will highlight in one of the cases, so many patients are missed because we only go on symptoms like headache, vomiting. If we could take 1 minute to just ask a few questions about cranial nerves, many tumors could be localized. So cranial, as we all know, we have 12 cranial nerves, 12 pairs of cranial nerves rather. Cranial nerve 1 is for smell, which we are very well aware, but cranial nerve 1 generally does not get so commonly affected in pediatrics, hence I have not mentioned about it, though there are some rare tumors. But cranial nerve 2, so optic nerve, ask only one question: is the child seeing as well as the child was seeing before, or does he have visual disturbances? Now, 3rd, 4th, and 6th can be put into one group. You can just ask if there is any squint or deviation of eyeballs. This is history taking. So any visual disturbances, any squint, and sometimes there can be ptosis. So if he can't open or close his eyelids, that will, so if he can't open his eyelids, it's ptosis, which means 3rd nerve. If he can't close his eyelids, it's the 7th nerve problem. Then again, so 2nd, 3rd, 4th, 6th, then we come to the 5th nerve, which will mean facial sensory and facial jaw movements. So, these are quick questions. Does he feel equal sensation on both sides of the face? And can he chew properly? 7th is obviously, this is very common, everyone knows, facial angle deviation and failure to close eyelids. Now generally we won't ask this question, but failure to close eyelids, so opening of eyelids, closing of eyelids. Cranial nerve 8 is hearing impairment or any problems with hearing. 9, 10th, 11th can also be put into one group, where you talk about a change in voice, difficulty in swallowing, and sometimes you can have a wry neck or a torticollis. And of course, 12th is tongue movement impairments, where the child will say that he's not able to move a morsel of food as well as he could in the mouth. Obviously, these historical signs or these history questions are difficult to elicit sometimes from infants or children, but you can ask your parents. So actually, if you see all these 12 cranial nerves, it takes 1 minute. You just have to ask the family, अच्छे से दिखता है क्या? आँख टेढ़ा हो गया है क्या? पलके खोल सकता है या बंद कर सकता है क्या? And then come down from the eyes, come to the face. चेहरे पे सब हाथ लगाने से समझता है क्या? चबा सकता है क्या? चेहरा टेढ़ा हो गया है क्या? एंड फाइनली, सुनने में कोई दिक्कत, आवाज में कोई बदल, निगलने में कोई दिक्कत. these questions, which took 5 to 6 seconds, if you have sort of this chart or maybe, this thing in front of you, these questions could be a part of your routine neurological examination. Of course, extensive neurological examination is not, it's beyond the purview of this presentation. But I think a quick OPD screening for these questions is very important and can clinch a diagnosis in many cases. Now, again, after cranial nerves, I think, I know this is becoming more of a neurology talk, but I think brain tumors are so much more in neurology. So therefore, again, so you see cranial nerves, then the other thing that you have to look about is power and sensations. If you don't have the time to examine a child in your clinic, just make him do these things. Walk on the heel, walk on the toe, stand on one leg. Your lower limbs are tested. A child who can walk on the toe, walk on the heels and stand on one leg, lower limbs are tested. Shake hands with the child, check his grip. If there is any tumor in the cortex, his grip will be weakened first. So even if you don't have...
Dr. Mahendra Patel, can you please mute yourself? Dr. Mahendra Patel. Yeah, thank you.
So even if you don't have the time to do a proper tone power examination in the upper limbs, hold the child's hand and check his grip. If the grip is good, that means generally you can say that the upper limbs are good. Now, again, cerebellar signs, if you don't have a lot of time, just make the child walk along a straight line on the floor. So if we have tiles in our clinic floor, just make him walk along the straight line. If tandem walking is impaired, you need not look for anything else. That will tell you that there is some incoordination. Of course, tandem walking can be impaired even in corticospinal lesions or in cerebellar signs, but I've put him in cerebellar signs here. And next, ask the child to count 1, 2, 3, 4 with the thumb on his fingertips. If I can do that fast, that means the cerebellum is intact. So you see, these two slides are very, very critical, and this can complete a neurological examination in 2 minutes and help you clinch many things. Now, spine tumors, I think a few more questions which can be asked is one, is the bowel and bladder involved? Do you have any band-like pain around the chest or abdomen? Because we will not ask this for a brain tumor or a headache case. But if someone is having some problems in the legs or the hand, bowel bladder disturbance is girdle pain or girdle anesthesia around the chest or abdomen. Now, again, remember, many spinal cord tumors cause something called syringomyelia. Let's forget about syringomyelia at the moment, but what it can cause tingling numbness in both upper limbs. It can sometimes long-standing benign tumors. They can cause wasting in the hands. So when you are shaking hands with the child, have a look at his thenar eminence, compare it with the opposite side. If you feel they are wasted, it could tell you that there is something ongoing for a long time. And of course, radicular pain in lower limbs. And this last symptom, which I have highlighted with 2 asterisk signs, suboccipital pain. So like I told you, I'll go back to my previous slide. Have a look at this thing. When there is anything that is increasing here, raised pressure here, what the brain does is the brain tries to squeeze its contents outwards. The biggest foramen through which the brain can squeeze its content is the foramen magnum over here. So when there is raised pressure, the tonsils start herniating through the foramen magnum, and therefore occipital, suboccipital. This is the neck region, just where the hairline is ending. Many times tonsillar herniation can present as suboccipital pain. So if a child is complaining of headache, it will be worth asking whether the headache is in the suboccipital region. That is just where the neck begins. That's a very critical history and which can at times tell you that something is ominous. Obviously, then if you have these symptoms and say you send the child for a radiology and you know that there is a tumor. I think this is one important thing. We bombard the child with anti-epileptics. At present, there is no literature evidence to suggest that anti-epileptics should be started for any child with brain tumor. Especially infratentorial tumors, the incidence of seizures is very low. Supratentorial tumors can cause seizures, but I think prophylactic AEDs have no role. So the child should be, and in fact, prophylactic AEDs offer no benefits, have no better seizure control also. So the dictum generally is you do not give anti-epileptics till the child has seizures. Obviously, once the surgeon has operated and we have made, a cortical incision, we have injured the cortex iatrogenically, then we start seizures as prophylaxis. Corticosteroids, again, like we know, corticosteroids are very effective for vasogenic edema. Now, dexamethasone, many drugs have been tried. I know there are other neurological conditions where methylpred and so many other things are tried, but for vasogenic edema in brain tumors, I think the most preferred drug is dexa. Unfortunately, there is no standard dose for dexa in brain tumors. We generally, the dose, therefore, that I've given here is from practical experience. Depending on, say, if the child is less than 10-year-old, I think, or less less than 5-year-old, I think you can give a 2 milligrams TDS to QID depending on how much. So 8 milligrams a day to 6 milligrams a day. If it is 5 to 10-year-olds, I think you can then go from 10 to maybe 12 or 14. And if it is a proper, say, a 13, 14-year-old, almost like an adult 50 kg child, you can go up to 16 milligrams a day. It is good to load with a big dose and then give divided doses. So antiepileptics and corticosteroids. Now, I thought I will include this slide because, when I was talking about clinical examination, I remembered from my neurosurgery training days that no clinical examination is complete without looking for neurocutaneous markers. I'm sure I might not be the right person to talk to physicians about neurocutaneous markers, but nevertheless, with the perspective of brain tumors, it is always good, especially because you have these congenital syndromes in children. You don't see these in adults. It is necessary to maybe just unbutton the shirt and have a look at the whole body, including the face. So I've just talked about two important neurocutaneous syndromes that we see and which can present with tumors. Obviously, tuberous sclerosis, we know that it is notorious for causing seizures, and there are many presentations and many causes of seizures. But tuberous sclerosis is also associated with giant cell astrocytomas, especially in the third ventricle region, which can cause hydrocephalus. So, like you see here, you can see adenoma sebaceum. You can see an ash leaf spot or a sort of a confetti-shaped hypomelanosis here. And you can also look for ungual fibromas. So it is good to screen them, because if you see this and then this child has a headache, you don't have to waste time and screen the child immediately. Same again, we are coming to neurofibromatosis. Obviously, this is very well known to everyone. Neurofibromatosis presents with various brain tumors and spinal cord tumors. Of course, neurofibroma type 2 does not have a lot obvious neurocutaneous markers, but neurofibromatosis type 1 can present with neurofibromas or plexiform neurofibromas. You can have the leash nodules if you look at the iris through direct ophthalmoscopy, and then you can have axillary freckling. And of course, on imaging, like you see here on the left side, everything is normal, but here, this is the sphenoid wing. So the sphenoid wing is hypertrophied, and because of which sometimes the eyeball can pop out. There can be proptosis on one side in neurofibromatosis. So this sort of completes how you evaluate or assess any child that maybe presents with any neurological condition, but when there is a suspicion of, a CNS condition, this is what you should complete in your history and examination. Now, I think there are many brain tumors. I think classifying brain tumors and all would have become too technical. So I thought I'll just mention the common ones that we see in pediatrics. Like I told you, the infratentorial compartment is a small compartment, but unfortunately in pediatrics, 60% of the tumors are in the infratentorial tumors, so-called the posterior fossa tumors. We all have heard of medulloblastomas. Then we also know of juvenile pilocytic astrocytoma. Now I've written here benign because this JPA is a benign tumor, and therefore the only treatment is surgery. Wherever I have not written benign, it means that these tumors can have a variable behavior and prognosis. So medulloblastomas, pilocytic astrocytomas, ependymomas, choroid plexus papillomas and carcinomas. Papilloma will be benign, carcinoma malignant. And these two tumors, which are exclusively again found only in pediatrics. One is the diffuse intrinsic pontine glioma, the DIPG, and the atypical teratoid rhabdoid tumor. So again, sounds like big names, big terms, but these are common tumors seen in the pediatric age group. Again, supratentorial tumors, astrocytomas, gangliogliomas, craniopharyngiomas, and then the PNET, DNET, and germ cell tumors, supratentorial tumors. So I think it suffices to remember that infratentorial tumors are 60%. So therefore, most pediatric cases would present with signs of posterior fossa. Supratentorial tumors are only 40%. And like you said, this is sort of a rough distribution. Now, I thought I should give the survival rates of some common tumors, especially the ones which fall in the so-called malignant region, because sometimes, certain families get prognosticated or counseled that, एक बार brain tumor हो गया तो फिर शायद इसका कुछ नहीं हो सकता. So, I mean, in today's day and age, if we are treating everything from leukemias to lymphomas, to, we are doing BMTs, if everything else can be done with aggression, I think these tumors with these survival rates are worth operating. Although in this, like you see, a medulloblastoma has sort of a 70% 5-year survival rate. Now, this is a 5-year survival rate that I'm talking about. And if it has spread to the spinal cord, 60% 5-year survival rate. So 6 out of 10 children with medulloblastoma, even with spread to the spinal cord, will live for 5 years. Of course, there are many more details in this, depending on how much is left after surgery, what is the age of the child, what is the spinal cord metastases, and also, there are new classifications, molecular classifications of medulloblastoma, which will again, subdivide this survival rate. Obviously, one thing that we have to remember that any child who's less than 3 years will do very poorly because, we have limitations of adjuvant therapy. Primarily, we cannot give radiation to a child less than 3 years, and that limits that sort of ties up our hands. Ependymomas have a 10-year survival of around 50 to 70%. This last group is something which you will, I needed to mention it because gradually, as you have more and more posterior fossa tumors, many posterior fossa tumors, which initially were thought to be medulloblastomas, have turned out to be ATRTs. This is a term which has sort of come up in the last decade or so. As pediatricians, I'm sure sooner than later, you will see many of your posterior fossa tumors coming with this histopathological diagnosis. So it's good to remember at least the abbreviation ATRT. And in general, these tumors do not do very well. And like you are seeing, a 5-year survival is less than 30%, sometimes even less than 10%.
What does ATRT stand for?
Yes, madam. So ATRT stands for an atypical teratoid rhabdoid tumor.
Okay.
Yeah. So this is many of these passed away as medulloblastomas in the past, but now we have some molecular markers which identify them, and so we can differentiate them from medulloblastomas because they don't do very well. So that is it. So I think with this, I have maybe 2 or 3 cases. Which in fact here we could maybe discuss what we would think, how we would go with these cases forward. A 10-year male child. This is in fact a child which I have operated here at SRCC a couple of weeks ago. The family came to me from Raipur. The child had lethargy for 10 days, vomiting for 5 days. Generally, the child was weak. I mean, the family was saying, बहुत कमजोर हो गया है, ज़्यादा बातें नहीं करता, चलना नहीं चाहता. And the child was having mild to moderate headaches. This child, obviously, initially was symptomatically for almost 5-7 days because the child was conscious. He was sleepy, but he was conscious. He was even eating. Despite the vomiting, he was eating. And so eventually, I think the treating physician thought that this is a gastroenterological problem, and hence he was referred to gastroenterologist. And rightly so. But why I have now, I will try to highlight one point because of which, maybe my whole logic for running through the neurological examination will come up. This is what the child showed on examination. The child preferred to sleep, but was very easily aroused. But like I said, if we had looked for so basically, sometimes they say the face tells you everything about the person. Even on a neurological examination, the face pretty much tells you everything about the person. This child had difficulty opening his eyelid. This child had ptosis. It was a partial ptosis, but you could make out the moment you see him that one eye is almost closed. And when you shine a light, obviously it is pupil sparing. So generally, if I can just simply tell you, pupil sparing ptosis is because of third nerve palsy. So pupil sparing third nerve palsy occurs in medical conditions, generally inflammation, infection, because the third nerve on its surface has the pupiloconstrictor fibers. So if there is a tumor which directly presses on the third nerve, when the third nerve emanates from the brainstem and on its course to the orbit, if there is a tumor which presses on the third nerve in its course, then it will cause a pupillary dilatation. But here, if there was a tumor, if we just try to localize, this tumor is not somewhere along the course of the third nerve. So then either this is not a tumor at all, or else this is a tumor which is before the third nerve has come out of the brainstem. So maybe the third nerve nucleus level. So therefore, when you see ptosis, because one of the neurology fellows here told me that, sir, usko ptosis hai, lekin uska pupils react kar raha hai. So then we had a discussion. We said, so I told her to look up pupil sparing third nerve palsy. So basically, remember that pupil sparing third nerve palsy is mainly medical conditions. Very rarely a tumor will cause pupil sparing third nerve palsy. If there is a tumor which is pressing on third nerve, it is generally going to cause pupillary dilatation. And more important, the last thing, he could walk, but I just asked the child to walk along a straight line on the floor. The child could not tandem walk. Now with all of this, we had the images. I'm sorry for the poor quality of the images, but if you look at this image is a little more telling than the previous one. Like if you remember the normal brain MRI that I talked about, this is a T2 weighted MRI because you can see CSF is white, so it is T2. Supratentorial compartment, infratentorial compartment. I'm sure you all can make out there is this big gray lobule here. Now there is a big gray lobule here. Now, like I told you, there is this aqueduct here. So the lateral and third ventricles had to drain through the aqueduct into the fourth ventricle. This tumor is blocking the aqueduct. And if we see on these images, these are the two lateral ventricles, the Mickey Mouse ears, which are the frontal horns of the lateral ventricles. This tumor is coming from this side and blocking the foramen of Monro as well, because of which this tumor will not drain into the third ventricle also. So only the lateral ventricle will enlarge. I'll go back to the image. I know it's getting a little radiological, but just for understanding, this tumor is here. Because this tumor is here, it is not letting CSF flow here. Also, this tumor is here. So lateral ventricle had to flow into the third ventricle. If the tumor lies here, the foramen of Monro will be blocked. So you realize what will blow up in this child? Only lateral ventricles will blow up. And because this tumor is coming from the right side, it will block the foramen of Monro on the right side. So right frontal horn will blow up more, left frontal horn will not blow up as much. So so this was how the radiology presented. So yeah, so basically this was the tumor. We then had a tumor board meeting. Initially, I did an endoscopic procedure. So I used an endoscope. I went into the ventricle because, like I told you, both ventricles here are not talking to each other. So I have to make a hole here in the septum, so that one ventricle starts talking to the other. After that, I also tried to take a biopsy from this tumor. And I thought this is a minimally invasive procedure. We'll stop at that. So the biopsy showed that it was a glioma. But then obviously we had a discussion with the Tata radiation oncologist, Dr. Tejpal Gupta, and he suggested that, I should try to debulk as much as possible and also send this tumor for molecular markers and immunohistochemistry. So remember, in the past, all tumors were classified only on the basis of histopathology. This tumor came out to be diffuse midline glioma. The molecular marker was H3K27 mutation. So I just need to tell you, this diffuse midline glioma is a new category made by WHO. Whenever there is a glioma in the midline, so this is midline, there is a glioma like this, which is big. It can be here, it can be in the brainstem, where we call it the DIPG, or the diffuse intrinsic pontine glioma. So any glioma in the midline generally can portend a poor prognosis. So the best way is to be safe, do as much debulking safely without giving deficits. And if you get this molecular mutation positive, this becomes a diffuse midline glioma. The survival is very, very poor, 10 to 12 months. Obviously, I did a VP shunt for this child later. The child has gone back home. A few days ago, the family contacted me saying that the child is doing very well, is conscious now, eating, walking with support, but the family has understood, and I have explained to them that this child won't live beyond a year. They have chosen not to undergo any radiation and keep the child at home. So what I would want to highlight here is, although here this was a very malignant disease, so a short history of 10 days, but sometimes a benign situation where, referral to gastroenterologist or managing symptomatically without proper neurological examination, this can sometimes lead to a delay in diagnosis. So this was one case. Let's go to another case. Now, this, in fact, was a case from London, which also opened up my eyes to the fact, obviously, it was my first 6 months in London, and this is Great Ormond Street is one of the best pediatric neurosurgical centers in the world. But remember, all cases get referred to Great Ormond Street also through the referring, system is what the patient first goes to a GP, not even a pediatrician. So in the UK, in the NHS, if you do not have a major problem, you do not have an assigned pediatrician. Like in India, we have the liberty of sometimes visiting even 10 pediatricians. Their kids do not have access to pediatricians. So if they have a problem, they visit a GP. So this child, this was the case I was talking about, the London case. So this was a 13-year-old female. was unsteady while walking since a very long time. So she would walk, she would run, but she was unsteady while walking. Gradually, this progressed to dragging a foot while walking, and she had pain in the hips. So you can see these symptoms were going on for a year. Unsteady while walking, gradually progressed to dragging, and because she had pain in the hips, everyone thought this was some trauma because she used to do a bit of trampolining also. So they thought this was some trauma. There were multiple referrals to orthopedicians, and the orthopedicians also did not find anything. She was undergoing some physiotherapy, but no one possibly ever neurologically examined her that well. Maybe also it was a time of COVID, and hence, remote examinations did not help the child any further. One day she presented to the ER with urinary retention. And that was sort of the last nail in the coffin. On examination, when we saw the child, she had significant weakness in the right leg, around 3/5 power. Sensation was impaired in both legs, right greater than left, and unfortunately, she had bladder incontinence. Now, here I need to point out a very important point, also because I do a lot of spinal dysraphisms. Bladder fibers are very, very sensitive fibers. And therefore, if anything in the spine, be it a tumor, or be it a dysraphism, or be it any congenital cyst, or anything for that matter, if it has taken the bladder fibers and the bladder fibers are involved, the chances of that recovery is very, very limited. So therefore, while prognosticating this family, we had to tell her that the bladder incontinence is something that might never improve. We did a scan, and like you can see, there was a tumor lower down in the lower spinal cord and conus region. Like you can see, this is S1, L5, L4, L3. So imagine the L3 dermatome, maybe the root of the L3 was caught up here somewhere. So if the root of L3 was caught up here somewhere, that can possibly cause some pain in the thighs or around the hip region, not so much more posteriorly, but more anteriorly, because the L3, L4 dermatome is the anterior aspect of the thigh. And this pain was attributed to trampolining and excessive sports. And again, multiple orthopedic referrals. Finally, we did operate on this child with intraoperative neuromonitoring. In today's day and age, doing these tumors without intraoperative neuromonitoring is a crime, because I know that there is a deficit, but I cannot give any more deficit to the child. So this child has to be done under motor evoked potentials, sensory evoked potentials, and triggered EMG root monitoring. Turned out to be a ganglioglioma, which was a grade 2 tumor near total excision, but there was no improvement in the bladder function. So, this case highlights that here a delay in diagnosis for almost a year to a year and a half cost the patient very dearly. Therefore, sometimes a neurological examination, if this child would have been made to walk on the heels or walk on the toes or walk along the along a line for tandem walking, and sometimes, we surgeons are blamed for not carrying a stethoscope, but I'm sure all you pediatricians always carrying a stethoscope. Even if you don't have a knee hammer, you can use the diaphragm of your stethoscope as a hammer and knock it on just below the patella, elicit the knee jerk. And if this child had brisk knee jerks, so, all of this, if it would have done the delay in diagnosis in this child, and this happens in a developed country, in the capital of a developed country. So, this is not more about not knowing. I think this is about missing something and an inappropriate neurological examination. Case 2. Now, we've talked about a lot of poor outcomes. Let's talk about some good outcome. 5-year-old female child came to me with headache, lethargy, vomitings, imbalance while walking. So again, 5-year-old. So with these symptoms, like, again, there is some imbalance, conscious oriented, but cerebellar signs were positive on the right side. This was what it is. So like I told you, an infratentorial tumor. So any infratentorial tumor will practically look like this, but this solid cystic presentation. Now, again, if you compare, you can imagine the aqueduct and the fourth ventricle. If you remember the previous scan, the aqueduct and the fourth ventricle, which was supposed to be here, are fully compressed. So everything superior to it is dilated. So a lateral ventricle and third ventricle is not so significantly dilated, but the lateral ventricle is dilated. Now, these kind of tumors, even when we see the radiology, we know these are pilocytic astrocytomas. I did a complete excision on this tumor. This was in the year 2018. This turned out to be a juvenile pilocytic astrocytoma. Very, very good prognosis. In fact, they were from Konkan. The family just gave me some very tasty mangoes a week ago, and I was very happy to see this child after 3 years after COVID. And we did a scan which shows no recurrence. But what I need to highlight is this: this child did not need a shunt. Now, this is where maybe my experience in pediatric neurosurgery has helped. Before entering into pediatric neurosurgery, maybe I would have first put in a shunt. But now we realize, because there is hydrocephalus, so we realize that if you put it, so the child has presented with raised ICP features, so we put in a shunt and then think about doing the tumors. But now this is established, this is an established guideline that, especially by the International Society for Pediatric Neurosurgery, that when you see a posterior fossa tumor with hydrocephalus, unless the child is comatose, you do not drain the CSF, you directly attack the tumor. Because once you can, if you can completely excise the tumor, you can possibly give the chance to the child for leading a shunt-free life. Because we know that if we put in a shunt once, shunt can have its complications. So this is a point that needs to be highlighted, that not all patients presenting with hydrocephalus need a shunt. And of course, there are no recurrence after 4 years. This is a very, very good tumor to have if someone has to have a posterior fossa tumor. So after this, I think, just want to highlight, I mean, even though tumors are important and seen commonly in pediatric versus adult, there are 3-4 issues which make pediatric tumors and especially pediatric neurosurgery more difficult and critical. And also, you basically, like I said, more than knowledge, you need a different mindset to deal with brain tumors in pediatrics. One is the CSF dynamic in children is very different. Like I highlighted in this case, normally someone would put in a shunt. Remember, if you put in a shunt in this child, it can also cause upward herniation, because suddenly you reduce the pressure. All of this can herniate upwards rather than downwards. If it herniates upwards, it can be fatal. So again, CSF dynamics are very different in children. Again, pathologies. So all these different types of tumors that I talked to you about are almost exclusive to pediatrics. You do not see them so commonly in adults. Therefore, the way to approach them and what we need to do with them in terms of adjuvant therapy and also in terms of surgery is very, very different. Also, the most important rate limiting factor in any pediatric neurosurgery is blood volume. When I used to operate on adults, we had an adult who was 70 kilos with a 5 liter of blood volume. I mean, 1 liter blood loss would not even, cause any hemodynamic change on the anesthesia monitor. But in a child who is maybe 2 months old, or sometimes even a 2 years old or a 5-year-old with a blood volume of around a liter or a liter and a half, maximizing tumor resection and minimizing blood loss, it is a very, very, very sensitive balance. And that is what makes the key to good resection and good intensive care post-surgery. I think none of my surgeries can have a good outcome if I do not get good PICU care. In fact, the child from Raipur, the child with the diffuse midline glioma that I told to you about, underwent 3 surgeries, an endoscopic surgeries, then a craniotomy, finally a shunt. Because it was, the tumor was involving the thalamus, the child was drowsy post-op and stayed in the ICU on ventilator for 2 weeks. And I was thinking this child will finally have to undergo a tracheostomy. But thankfully, our intensive care team here is very, very good. We could extubate the child, and finally they could put the child in a normal ambulance and take him back home to Raipur, where he's now doing well at home. So I think any neurosurgeon without a good intensive care team is almost incomplete. So, and this becomes very important in pediatrics, because we neurosurgeons, remember, we are surgeons, we are not physicians. And also, more importantly, we are not pediatric trained. That is the critical thing. When we operate adult, we sort of extrapolate our general surgical and some medical knowledge to adult neurosurgery. But when I'm doing pediatric neurosurgery, I'm heavily dependent on a pediatrician, even for dosage of medicines, let aside other, intensive care things. So I think, therefore, for a pediatric neurosurgeon to have a good outcome, a good pediatric ICU is a must. And then finally, I thought this would be a good case. Not all pediatric brain tumors are malignant, but sometimes they become challenging in the perspective of what I was telling to you, eloquence of the brain. Now, this was an 8-year-old male child, focal seizures, right clonic seizures affecting the upper limb. Examination was completely normal. I don't have the MRI here, but basically it showed an MRI just behind the motor cortex. So if I can actually go to the first slide, this is the motor cortex. This patient had an cavernoma somewhere here. So now you realize, I wish the brain was labeled like this when we opened it. But unfortunately, the brain is like this when we open it. It's very difficult to say what is the motor cortex, what is the central sulcus. That is where radiological correlation becomes very, very significant. We have something called the neuronavigation with us, which we use very, very commonly for epilepsy, but also for these eloquent cortex tumors, like I told you, close to speech area, close to motor areas. So with the help of neuronavigation, we tried to, isolate where the motor strip could be. But then the problem that becomes is, I think this is the motor strip. Now, when I do cortical stimulation, now remember, this was an 8-year-old child. The gold standard is an awake craniotomy. Awake craniotomy is the best way to tell you if you are hitting a white matter tract that you should not be hitting. But the problem is this 8-year-old child was not ready to cooperate. Now, this is again another limitation in pediatric neurosurgery. A 30-year-old or 40-year-old will cooperate for awake craniotomy. So if I would have done an awake craniotomy in this child. But this 8-year-old was very fidgety. He was a little irritable, obviously, and scared, obviously. And so he needed a lot of counseling, but he was not ready to cooperate for an awake craniotomy. So what was I left with? I was then left with cortical mapping. So basically, cortical mapping is a technique where we use a probe like this. This is a monopolar probe. We use it to stimulate the brain surface with a current. And gradually we keep going up with the current. During that time, we have to take precautions that the anesthesia is such, it is only TIVA, it is total intravenous anesthesia. So there is no muscle relaxant. Because if there is a muscle relaxant, I cannot see muscle movement. What I'm trying to elicit here is I'm trying to use a probe to stimulate the brain and see if this is the hand area. And if this is the hand area, the hand should move. That will tell me if this is the hand area, that means I need to stay away from it. Now I did cortical mapping and confirmed this is the motor area so that whatever I do, I will stick to this gyrus and I will not touch this gyrus. Had this been a non-eloquent area, I could have been very aggressive and resected a big, good area like this. But here I had to stay behind this gyrus because I could not have given him a deficit. Neuronavigation helped, cortical mapping helped. We removed the tumor without any deficit, complete excision. And this is another very, very important tool, which is called DT, tractography or DTI, diffusion tensor imaging. So whenever we see that there is a tumor close to eloquent area, of course, we do it routinely in all epilepsy cases, but also in brain tumors, whenever there is a tumor close to an eloquent area, like the motor cortex or the speech areas, we do this tractography. These are the tracks. So like you can see, this is from the motor area, these are the corticospinal tracts coming down and going into the brainstem. The cavernoma was somewhere here, but it was not disrupting the corticospinal tracts. Therefore, my idea post-surgery was to keep this image as it is, and we ended up achieving that. So again, these are tools which are very, very critical for eloquent area surgery. Obviously, we do a lot of epilepsy surgery, and therefore these tools for cortical mapping and navigation and awake craniotomy are very commonly used by our team, and hence this also helps me during my brain tumor surgeries. So I think, yeah, with these 3 or 4 cases, I sort of tried to project what could be the presentation, what could be the challenges that I face. And yeah, hopefully it has helped you all possibly get some sort of an overview of what brain and spinal cord tumors could look like. I'm happy to take any questions, and we can have an informal discussion if at all. Yeah, thank you so much.
Am I audible, madam?
Yes.
Yes, thank you, sir. Thank you.
Thank you.
Got
Thank you
an
so much.
overview from anatomy to radiology to surgery.
Thank you.
Thank you very much. So you brushed up on our anatomy, then our radiology also.
Thank you.
At least for few of our patients or our relatives, when we hold this MRI plates in our hand, we'll get to know which one is T1 weighted, which one is T2 weighted, and which are infratentorial and supratentorial tumors.
Right.
And again, you told regarding these newer techniques about cortical mapping, neuronavigation, tractography. These are not heard words for us.
Yes.
So in such a small time, you took us for a tour of neurosurgery. Thank you, sir.
No, thank you, Dr. Govind.
Sir, I have one question.
Sure.
How will we counsel these parents of these patients from a general pediatrician to go to a neurosurgeon, and what will be the prognostic counseling by you afterwards? And for a general pediatrician, how to counsel prognosis after surgery?
Right. So I think the first and foremost thing is that's why I tried to show you the survival rates for a few common tumors. I think except for, until we have the histopathology, we don't know what tumor we are dealing with. A short history can point towards a more malignant tumor. a prolonged history can point towards a more benign tumor. So that can be from history, that can be a rough sort of a guide. But at the same time, I think in today's day and age, with the adjuvant treatments, it is possible to give, especially like I said, for this girl from Konkan with a pilocytic astrocytoma, she's going to have a normal life and she's going to have babies later on and she's going to live a normal life. So for her, if we look at a posterior fossa tumor and, if sometimes due to lack of awareness, if she's told that the child will not do well, then I think that will be unfair to that child. But overall, I think in terms of counseling, you should definitely first see how urgent it is, because you need to know whether you can send the child back and call the child later, or you need to send this child immediately to a pediatric neurosurgeon. So again, therefore, I thought that imaging was critical. Look for hydrocephalus. If there is hydrocephalus, I'm sure you know all this, but if there is hydrocephalus and if there is a lot of edema, if there are these two things, and like I told you that question about suboccipital pain, so hydrocephalus with suboccipital pain means this child can have impending tonsillar herniation. So therefore, you have to counsel the child saying that this is hydrocephalus, there is a blob that I'm seeing in the brain. And with these symptoms, and if you are having nausea and vomiting and suboccipital pain, you have to see yourself in a pediatric neurosurgeon's clinic straight away. Obviously, a comatose or a drowsy child is like a no-brainer that you obviously will refer. The only tumors which are possibly can be kept on an OPD basis, which actually I did not include because these were brain tumors, are tumor-like conditions, like an arachnoid cyst, a colloid cyst. These are cysts, and many a times, on MRIs for headaches and MRIs for some visual problems, you'll see arachnoid cysts, you'll see colloid cysts or cysts here and there, or enlarged cisterna magna. If there is no hydrocephalus, although remember arachnoid cysts can cause hydrocephalus, and again, that becomes an indication for operation, but mostly tumor-like conditions without hydrocephalus, without edema, and when the child is fully coherent and conscious, can possibly be kept on a follow-up. And then you can maybe, if you are in doubt, depending on the size, you can involve a pediatric neurosurgeon. Maybe you can do a fundus, although a fundus will not always tell you whether there is raised pressure, but many a times, to tick the box and also to be medically legally safe, if there is an arachnoid cyst, which may be more than say 1 centimeter, it's good to do a fundus so that you have a baseline. And then after 6 months, if you repeat a scan, for example, sometimes you'll see small pituitary adenomas, not very common, but small pituitary adenomas, and the child is completely normal. So you do the whole endocrinology workup, and then you can follow up that child if the vision is okay. So do your visual fields, do your endocrinology, and if all of this is normal, it's a less than 1 centimeter pituitary adenoma and not causing any compression, then you can follow up this child. But any ominous symptoms of raised pressure, and like I said, eloquence, so speech disturbance, personality change, behavioral disturbance, if the child is not who he was as before the situation, this child needs immediate referral.
Okay.
One question I want to ask.
Sure, madam.
Can biopsy make cancer tumor cells spread faster? Like tumor cell seeding is done. That is the reason we should avoid biopsy, they say.
Yeah, so that does not hold good with brain tumors, madam, brain or spinal cord tumors. In fact, so we do all kinds of biopsy in CNS. Like we do it, like in the first case I discussed, I put in an endoscope and took only a small tumor because I knew it was inoperable, so I could not remove the whole tumor. So this seeding due to the surgical tract that you're asking about is not known in CNS tumors. So they can very safely be done. Sure.
Yeah, I wanted to ask you about endoscopic surgery for hydrocephalus with just aqueductal stenosis.
Yes, ma'am. So yeah, today the treatment of choice for a child with aqueductal stenosis is endoscopic third ventriculostomy. If you remember from the MRIs that I was showing, the third ventricle, we make a hole in the floor of the third ventricle with an endoscope. The only thing is, I think the present guideline, so there is an ETV, endoscopic third ventricular success score, ETV-SS. Any child above 6 months, any child with pure aqueductal stenosis, which is an obstructive hydrocephalus. So obstructive hydrocephalus, that too due to aqueductal stenosis or a tumor or a tectal plate glioma, so anything which is causing obstruction, more than 6 months, without infection, without bleeding in the ventricles, the first surgery to be done is an ETV. and we should not subject that child to a shunt. Only if the ETV fails. In fact, even if the ETV fails, we can do redo ETV. And many times nowadays, even for failed shunts, if there is a possibility depending on the MRI, we sometimes offer ETV rather than shunt revision, because if we can get rid of shunts, that is one of the best things. Unfortunately, yeah, many cases communicating hydrocephalus and all, ETV is not so good. So mainly obstructive, aqueductal being one of the most important indications, and more than 6 months, we should do ETV.
So it is just making a hole in the floor of the third ventricle?
Yes. So basically what we are doing, if I can sort of, I'll just use this to just show you the MRI once again. Resume slideshow. Yeah. Yeah. So what we do in an ETV is we come from here. We come from here. Now see, you are saying the patient has aqueductal stenosis. That means everything below this is blocked, correct? So everything above this will be blown up. So what we do is the scope comes from here. The scope comes from here, enters the lateral ventricle, enters the foramen of Monro, and then, see, this is the basilar artery. This is the mammillary body. This here is the mammillary body. So these are our landmarks. We bring the scope and make a hole. In fact, we are seeing the third ventricular floor in this scan. It's a good scan. We make a hole in this third ventricular floor. So now what is going to happen is, normally CSF would have flown from lateral ventricle to third ventricle to aqueduct to fourth ventricle, and then through all these subarachnoid spaces would have spread all over the body, or all over the brain. Here what we are doing is, because all of this is blocked, we are making a hole here. Rather than this posterior outlet, which was normal, we make an anterior outlet just in front of the mammillary body. Now from here, the CSF then again flows all over the brain and gets absorbed. So this is what we do in ETV. So the hole is made here in the floor of the third ventricle. This is the third ventricle, we make a hole here.
Nice.
Any other questions?
Are there genetic markers for the prediction of outcome of or prognosis of any brain tumors?
So ma'am, genetic, yes. I mean, if there are known syndromes, like I said, neurofibromatosis, tuberous sclerosis, Sturge-Weber, and all of these, obviously there are genetic markers. But more importantly, there are molecular markers now which are being done for every tumor case. And molecular, like medulloblastoma also, right now, medulloblastoma are classified into 4 types. I'll not go into the details of all of that, but there are 4 molecular subtypings of medulloblastomas. Each molecular subtype behaves differently from the other. So like the first molecular subtype has a very good prognosis, so which I showed 70%. In fact, the first molecular subtype can really do even better than 70%. So if we get that molecular marker on the medulloblastoma and there is no CSF spread, then we can in fact prognosticate the family saying that this child is supposed to do better than the other medulloblastomas. This change has happened since 2016 when the WHO CNS classification came out. Similarly, for ependymomas, there are posterior fossa ependymoma type A and type B based on molecular marking. For, like I said, diffuse midline glioma, that child from Raipur, which unfortunately will not do so well, we could prognosticate with confidence because we found the histone mutation H3K27. This is a known mutation today. Again, for ATRT, there is a genetic mutation called SMARCB1. If we get that, we know it is ATRT. In India, even across the world, if the diagnosis of ATRT is there, I remember in Wadia also there was an ATRT child, and we just told the family that nothing can be done. They took the child home. But when I was in London, they were doing some trials on some drugs which are targeted at these molecular subtypes like H3K27 genetic mutation. So there is a drug which will target this mutation. Maybe in the coming years, something will change. But yes, so targeted therapies and molecular therapies are really coming up. Many of those drugs are available in India. Some obviously due to lack of cost can be a problem. But therefore, yes, counseling and prognostication in these days only on histopathology is not done. We send all our tumors for immunohistochemistry and molecular marking, molecular subtyping.
Sir, where this CT scan stand? Because
yes,
in resource limited.
If the patient is not coning, if the patient is not comatose, don't waste your time and the patient's resources on a CT scan. CT scan later, because MRI overall gives us more information than CT scan. What CT scan can sometimes help, sometimes in fact neurosurgeons end up intentionally doing a CT scan even though we have an MRI, is when you want to see for any bleed or any calcification, any calcium in the tumor. Because CT, like, on the CT, the bone looks white. So CT is good for bone, blood, and calcium. So sometimes like a craniopharyngioma, we don't know whether it's so craniopharyngioma and pituitary adenomas occur in the same region, cellar, supracellar region. Even germ cell tumors occur in the same region, cellar, supracellar region. If we need to differentiate, we need to see calcium. There are certain MRI sequences which I didn't talk about, like susceptibility weighted imaging and GRE and so on and so forth, which can tell you whether it's blood or calcium. But sometimes CT is done to differentiate. But overall, if the patient is not coning and is relatively okay, I think doing an MRI in today's day and age is better than doing a CT. Of course, if the patient is bad and we need to save time and we just need to put an EVD or a shunt immediately, then obviously a CT. And also because CT takes less time, sending a child for an MRI can be dangerous if the child is not conscious enough.
Okay, any more questions? Thank you. Thank you very much, sir.
No, thank you so much. In fact, Dr. Guge, you should not be calling me sir at all. I think we're all the same age, and I have very, very senior pediatricians and teachers here. I have to say, I'm very, very happy for this opportunity. I hope I have been able to add something to your knowledge of brain tumors and spinal cord tumors. And sort of as a parting message, I'll always say that, obviously, once a tumor is diagnosed, you will always refer it to someone who handles the tumor. But I think that neurological examination bit is something that I needed to emphasize. It'll help you, it'll stand you in good stead even for your other neurological cases. But like a quick 3-minute neurological examination can sometimes make a big difference to children's lives. And again, yeah, not all brain tumors are bad, so we should not give up. And yes, the other thing is pediatric brain tumors I believe need to be done in a pediatric center with all the armamentarium and with good backup. Sometimes, of course, I think if it is not done that way, obviously, we can still get away with surgeries, but I think if we are unlucky, we can cause more harm than good. So pediatric neurosurgery that way is slightly different from adult. So hopefully it was useful for you all. But thank you so much. Thank you for having me.
Welcome, sir.
It was excellent, Dr. Saurav. And
thank you, madam.
Added a lot, and even this 3-minute neurological examination is something we will remember.
Thank you, madam. Thank you.
Yes, and Dr. Gopal, you were fantastic. You gave a lovely, wonderful overview of whatever Dr. Samantre had to say. And we are so happy we have this recorded so we can go through this again. Thank you, both of you. Thank you very much. And we meet again next Wednesday. Thank you, Dr. Samantre.
Thank you, madam. Thank you so much. Thanks, everyone.
Really nice, and we learn a lot.
Thank you, madam. Thanks for having me. Thank you so much.
Dr. Jayashree is the, it's her idea to have these Wednesday webinars, and we started it during the lockdown. And Dr. Hemant is our host every time. So thank you. Thank you, Dr. Hemant.
I'm hoping sometime we also meet in person sooner rather than later.
Khub bhala, Saurav.
Thank you, sir. Thank you so much. Thank you.
Thank you everyone who joined in today, who made time in an afternoon during siesta time to make time for learning. So,
thank you
very much.
Thank you, madam. Have a good day. Thank you.
Thank you.
Shall I close the meeting?
Yes, sir.
Thank you so much. Thank you.
Bye.
Thank you, Hemant.